Hi, and welcome to MedInsights Unleashed podcast. I'm John Collins, and I hope you enjoyed this new episode, and thank you for listening. Good morning. Today on MedInsights Unleashed, we have Professor Philip, Professor of Medical Oncology at Wayne State University of Medicine and Henry Ford Cancer Institute. Professor Philip is returning to us today to discuss the RASolute 302 trial, which is emerging research in pancreatic cancer. Before we begin, I would like to encourage all our listeners to review Professor Philip's previous 2 episodes, Understanding Pancreatic Cancer, Genetics, Early Action and Future Research. Quality of Life over Quantity of Treatment, a Revolution in Neuroendocrine Cancer. Professor Philip, welcome back to MedInsights Unleashed. It's always a great honor to have you with us today.
Thank you, John. And what a way of finishing the week before a long weekend being with John Collins.
And it's really great to have you. And how's the family?
Doing very well, actually. And yeah, I'm thinking of my younger daughter who's in medical school. And each day I think, well, all these new changes are coming along. Some are the great changes. Some of them are challenging for doctors. So I keep on thinking like a father.
You're really hoping that she's following in your footsteps?
No, my wife was not a doctor. She really put pressure on my daughter to not even think of oncology as a future career.
Well, we're here to discuss this groundbreaking trial, the RASolute 302 trial in pancreatic cancer. So it's pancreatic cancer in the United States. There's approximately 60,000 patients diagnosed a year and about 50,000 deaths a year. It's still a major cancer, and I know that you're a world leader and treater of this disease. So how important is the RASolute 302 trial?
Well, thank you for having me again. You're right. The pancreatic cancer is not a common cancer like we see with lung or breast or prostate. But at the same time, it's unfortunately a disease where most of the people who are diagnosed with the disease, they die of the cancer. And the reason for that is that we don't diagnose it early. That's one reason for it. We don't have a screening procedure to get the disease diagnosed early. But there's also a very important point, and that is the cancer itself is a difficult cancer to treat with drugs. If you compare other cancers that even in their advanced stages, you can treat them and get better results, we never had that. So, John, if you remember, for the last few decades, we didn't have any real good breakthrough treatment for this disease. And the topic of today is that, yes, we have a breakthrough treatment. It's not a cure for patients who have advanced disease, but it certainly is a way to try to make them live longer and sometimes much longer with treatment. So it's absolute breakthrough. And this is really what excites everybody. And you know what the people are saying and the way things are written about this new drug. So I'll be happy to discuss it further.
Yeah, it's a personal thing for me today on this particular episode. We've had 2 very close friends, one with pancreatic cancer, and one of my dearest friends just recently was diagnosed with neuroendocrine cancer. And both of those were diagnosed very late. And so it's very important, I believe, for this disease. And it just stuns me as to why we can't get on top of it as early as we can.
Correct, because a lot of the symptoms, and let me put it this way, when you get symptoms, unfortunately, it's likely than not, it's an indication of advanced disease. So sometimes people talk about why people don't report symptoms earlier. That's not really the major thing, because if you report symptoms earlier, doesn't mean that you're catching it in a very early stage. Sometimes there are some symptoms like the jaundice, yellow sclera, yellow eyes. That can be an earlier sign, but people who present, for example, with pain, a lot of people present with pain. It's really an indication of already it is an advanced disease.
So let's get into this study. Overall survival is twice that of the current standard of care. So can you start explaining who the patients were that were entered into the RASolute 302 study and what was the criteria? And then we can get into the genetics associated with the trial as well.
Yeah, certainly. So, just briefly, I just want to introduce the concept. For the last 2, 3, 4 decades, scientists worked on this KRAS mutation, KRAS pathway, it's a signaling pathway. And a number of approaches were introduced. Some went to the clinic and all uniformly failed. So this trial was based on a drug that can target effectively the KRAS signaling. And we think that the KRAS signaling really is in the heart of the development of pancreatic cancer. It's a very early mutation that happens. Other mutations can happen with time. But with the KRAS mutation, what it does is that it sends the cells into uncontrolled proliferation, which is the hallmark of cancer, metastases, and also we know that it causes immune evasion. It doesn't allow immunotherapy to work. So it becomes a very important target. Now we have the target. So this trial you're referring to was in patients who have received prior one line of chemotherapy for metastatic disease or advanced disease. So one line of prior therapy. In our experience, as you know, in the clinic, patients who fail chemotherapy frontline, there are two things that I have to really bring up. One is when they go on second line regular chemotherapy, which is what is available to us now, that chemotherapy doesn't really produce a real good prolongation of survival. And the average survival in clinical trials is like median is 6 months when you go to a regular chemotherapy. So that's one point. The second point I want to make is that not every patient who progresses or fails the frontline treatment goes on second line chemotherapy. And one reason for that is that the second line chemotherapy, with its side effects of chemotherapy side effects, is difficult to tolerate it by a fair number of patients. So people give different figures, but I would say in real life, patients who fail frontline treatment and then go on second line treatment is only 50% of the patients who go on second line treatment. Why? Because of the two factors, the side effects I mentioned, but also the perception that why should I give second line treatment when the benefit is so limited and the patient gets side effects? So this is the foundation of us thinking why this clinical trial is important. This clinical trial is exactly those group of patients who failed frontline treatment and went on to second line treatment. But how did this trial perform, both in terms of its efficacy, but also in terms of the side effects that the patients may experience? So this was a randomized phase 3 trial, prospective randomized phase 3 trial, and it was in patients who have, it wasn't really selected for certain mutations. All patients were included because it included patients who also have KRAS non-mutated or wild type. That was something you have to also be aware of. And that's a different discussion whether it works the same or not. We will wait for the results. Anyhow, it included more than 450 patients, and the randomization was for the drug as a single agent. Now we're talking about single agent daraxonrasib versus the what the doctor wants to give. It could be any of the single agent or combination chemotherapy drugs. So that's really what was in essence, the trial. Obviously, patients who have favorable performance status, which is standard when we go on clinical trials, patients who have measurable disease, etc., and also reasonable good organ function. The usual criteria, but the key thing is that it was second line, patients who failed frontline. And the primary endpoint of the trial was overall survival. So this is important because sometimes clinical trials have a different primary endpoint, but what matters to the patient is how long am I going to live getting this new treatment? And the median survival of patients who received the drug was 13.2 months. And the median survival of patients who received the standard of care, and we call it the control arm, was only 6.7, so doubling. doubling of median survival, John. This is
That's
with a hazard
incredible.
ratio of 0.4. I mean, you've been in this business for a long time. We haven't seen this in pancreatic cancer, and after it's also very rare in other GI cancers. So
Yeah.
this is a breakthrough treatment, and
Can
for
you
that,
explain to the audience what the hazard ratio actually means?
well, it's the risk of dying of the disease, basically, which goes along with what the numbers are showing, 6.7, 13.2. It's derived from the Kaplan-Meier curves, and they're looking at the survival curves of each arm, and then they look at along the entirety of the curve. And so rarely seen. And with this result, a breakthrough, and it earned a plenary session presentation at ASCO, which is going to be in a week or 10 days.
Yeah, I'll be there.
So certainly a major advance. But the question now is, I mean, we know this is not a cure of the cancer, but the question is, how can we really build on this advance and even push the curve higher, or I don't know how you want to,
Yeah,
or
higher. That's right.
higher.
Yeah,
So,
higher and longer.
so what do you think will happen now? Well, if we focus on what's going to happen with this drug, so one thing is that why don't we bring it to the frontline treatment? It may work even better in the frontline treatment. Why should the patients wait to get it in the second line? So that will be a major consideration. And sure enough, there is a trial which is going into the frontline, which has three arms or three randomizations. One would
Oh,
be, one would be the drug alone, one would be the drug plus gemcitabine and nab-paclitaxel, and one would be just gemcitabine, one nab-paclitaxel. So three-arm trial. And here we'd like to see, is the combination better than the single agent? And is the single agent better than the gemcitabine
yeah.
nab-paclitaxel, so they don't need chemotherapy? So the preliminary data on a study that was presented in AACR suggests that the combination will be better than giving it without chemotherapy, and chemotherapy obviously benefiting from the addition of the daraxonrasib. So this is really where we are in terms of this drug. Another way of trying to improve the survival and the 5-year survival is to use it in the adjuvant setting. And,
Yeah.
and there's a study that's launched in the adjuvant setting also as a maintenance treatment. So it's a very active field. It was revolutionized by daraxonrasib getting into it first, but there are also a number of other drugs and other companies working on similar drugs, but they work in different ways, trying to target the KRAS pathway.
Are those targeted agents, we haven't talked about the side effects associated with the daraxonrasib. How are the side effects versus those of chemo?
So referring to one of the studies with daraxonrasib, one of the earlier studies, and we will know much more about the details of the side effects of the Resolute 302 when we get the presentation. But based on a previous experience with it, which was actually published already, most of the side effects, John, are grade 1 or 2, luckily.
Oh, wow.
And the major side effect that people have to remember will be skin rash. So skin rash is close to, I mean, the majority, close to 90% of the patients will have skin rash. However, the troublesome skin rash, which is grade 3, is going to be less than 10%. And this is important because one of the key things when these drugs are prescribed, the doctor and the medical team taking care of the patient should be familiar with the management of the rash. It is not really that difficult because similar rash is being managed by other drugs we use, for example, anti-EGFR drugs. You yourself, you know how we manage rash for
Yes.
hepcidin. It's a matter of, it's a bit of a learning experience, but people have to put their minds into how to deal with it. The usual, for example, for the acneiform rash, which is the type of the rash we see with this drug, we use antibiotics like doxycycline. We have to be thinking of using topical steroids or even oral steroids, and dose adjustments, referrals to dermatology, etc. So this is going to be the major side effect, the skin rash. As I said, Luckily, less than 10% will be severe kind of skin rash, which is the grade 3 or more. The other side effect, which goes along with these kind of drugs, would be the oral mucositis, the pain in the mouth people experience. And again, the grade 3 is less than 5%, but almost half of the patients may experience the mucositis. A third of the patients may have grade 1, 2 nausea, vomiting. Some patients may experience anemia and the platelets might go down, all manageable. And less than 10% of the patients may experience liver function test abnormalities. All these, the mucositis can be managed by the usual way we do with other drugs, magic mouthwash, oral dexamethasone solution, etc., lidocaine, and again, the diarrhea could be another side effect that I didn't mention. That can be also managed the way we do with chemotherapy, the nausea and all that. Again, there's nothing specific about management of these other side effects, but again, the one that people have to be aware of will be the skin rash. Patients will end up, for sure, some of them will end up with dose reductions or temporary holding of the dose, but getting the drug stopped for side effects is really extremely unlikely.
That's amazing, really. All grades in side effects are important for patients to fully understand. And thank you so much, Professor Philip, for going through that extended list, because I think it's important for patients to understand that there is ways to treat the side effects, and also drug holidays are actually common in oncology as well.
It is, yes. Yeah, again, there's no question that any patient starting on the treatment, the expectation must be, both for the patient and the treating team, is that at least initially, that's the way I do it with oral agents I use, including the capecitabine, which we know both worked on, is that I see them, I keep touch with the patient at least weekly, myself or my team, just to see how they're doing. Because a lot of times early on, you can somehow tell which patients are going to do better than others or worse than others, and therefore you can start early with them. The worst thing is that to let things accumulate and the patient's feeling unwell and that they stop the treatment or they don't want to go back on treatment. That should never happen.
Yeah.
In my experience, at least in I worked, the places I worked, there are also people from the from our pharmacy, the people and the nurses, nurses who take care of the oral medications. They will also be calling the patients to see how they're doing. Pharmacy people might be calling. So this is really a group effort to make sure that, because the good thing is that this is a drug that has a high expected benefit to the patient. We didn't talk about this tumor shrinkage. This drug also
I
produces.
was going to ask you about that.
I mean, obviously, survival trumps everything. But really, all the endpoints of the study have improved, including tumor shrinkage, etc. And tumor shrinkage plays a big role in improving the quality of life of the patient
Mm.
who is troubled by like pain and other pressure symptoms that the tumor produces. So all in all, a great drug to have. But with all these things, they don't come free, as we know. Going back to the side effects, and I do agree with you that even grade 2 rash for some patients might be a hassle. And I fully understand that. So it needs to be like a good interaction with the doctor and the patient, try to minimize the side effects.
It's as you already said, multidisciplinary approach is critical for longevity of both the drug and the side effects, and that's really important that the patients see a multidisciplinary team surrounding their oncologist.
Yes, yeah. This is also going to be very interesting in a way because think of it, a 70-year-old, which is the average age, 71-year-old to get cancer of pancreas, they get frontline treatment back and forward every week or every 2 weeks, whichever it's given, IV, spending time. And then after after an average of, I don't know, 6 months or 5 months, their disease starts to progress. Now they have to go on second line treatment. Now, when they go on second line treatment, based on what we have, the average survival in the second line is 6 months of the best of situations because in clinical trials, 6 months, not in real life. it will be less. So you have a drug now, you don't have to bring the patient every 2 weeks to the infusion area. And and you're just giving the drug orally at home. They get it home, right?
Mm.
Uh,
It's
some
amazing.
some people call. I heard someone do a presentation at last year, time toxicity or something like that, because you're saving time for the patient to come to the drive to the infusion area, spend there for half a day, and then go home, come back 2 days later, have the pump disconnected, and you're doing it at home. In patients whose survival was going to be short. So really, it buys them also good time to be
Yeah.
away from coming to see me and my nurses.
Which is always a pleasure for every patient is coming to see you and your nursing
I
staff.
mean, they will be.
Unbelievable.
I mean, they will be coming to see me every few weeks anyway. But
Yeah.
I spend hours in the infusion area connected to a IV. So
Yeah, it's amazing. The development in oral therapy is amazing. You brought up an interesting point earlier that the average age is around 70, but the two friends that have been diagnosed are in their 50s to 60s. Is there an increase of this disease? Is it changing or is it morphing to strike the earlier patient?
So from my experience of several decades, there might be a bit of a younger age, but it's not as dramatic as I see with colon cancer, colorectal.
Okay.
Colorectal is much more dramatic than I see with pancreatic.
We should talk about colorectal cancer. There's been some major breakthroughs, so we can leave that for another podcast.
Today or later.
Oh, today would be good. I mean,
No, no,
the viewers would be.
let me go back to my patients.
Yes, I will. So, what's the future for you and your team at Wayne State University?
The most important thing is to understand when it comes to KRAS targeting, the daraxonrasib, KRAS, or the other drugs in this space, is how can we make them work better? So, John, you've been in this business a long time. One of our major challenges in treating a lot of the cancer is something called drug resistance. And for my patients, I tell them the immunity the body develops against the drug. It's not immunity as such, but it's like being immune to the drug effect, right? So even with daraxonrasib, we know that there is drug resistance that develops. The cancer cells try to evade the effect of the drug. So the future for me and everyone else is in the country, in the world, is to trying to, number one, think of what predicts drug resistance. And that's a difficult one, I can tell you. It's not easy. But the one which really is more practical to try to do is try to think of what combinations can go with daraxonrasib, what other biological combinations that can be paired with daraxonrasib so that the combination works better than a single agent of
Mm,
daraxonrasib. So that's really where the money is. And that's where the what we call the preclinical lab testing is working on, is trying to figure out what other drugs can also be combined with an anti-KRAS drug like daraxonrasib. So that's going to be very important.
without increasing majorly the toxicity associated with that combo too is going to
Correct.
be critical.
Correct. Very correct. So if you look at the study that is the frontline trial, they're combining it daraxonrasib plus chemotherapy. The dose of the daraxonrasib has been reduced from 300 to 200 milligram. Because they took into account the possibility of what you're talking about, the side effects combination. But the other thing is that one would like to know if a patient goes on daraxonrasib, let's say for a whole year, and then starts to have disease progression or worsening, we need to know what caused that disease progression, which other molecular signaling pathway that really caused it. Because if we know that, then we can add the other drug to daraxonrasib, or we can replace the daraxonrasib by the other drug. So this is exciting for investigators, for the basic scientists, for translational science, for clinicians to really come up now with a lot of possibilities. My prediction is that within the next 5 years, the survival of pancreatic cancer will easily double the 5-year survival kind of statistic.
That'd be fantastic.
So, because it will be, because of the other thing is that when you have something like this, a breakthrough, it also generates a great momentum. And why do I say that? Because for the last 3 decades, 95% or 98% of the clinical trials, prospective trials, phase 3 trials, with billions of dollars spent, I would say many millions, if not a billion or more, they were all negative.
Yeah.
So
I
people,
was involved in some of those negative trials.
there you go. So a lot of people felt that this is not an area to invest in. This is not an area to go after. Let's stick to places like breast cancer, like lung cancer, like colon cancer. Now this is really opening up the doors for more and more studies, people to invest in more drugs and studies. And there are many, actually, for KRAS targeting, like the daraxonrasib, there are many companies now are working on it. But even within the company that has daraxonrasib, they have other drugs that work on KRAS, looking at different angles of targeting KRAS, like allelic, like drugs that only target, for example, G12D. Daraxonrasib is a pan-KRAS. It doesn't matter what KRAS mutation, but they also are working on 12D. So there are other companies also working on a number of approaches looking at targeting KRAS. Again, because people are now encouraged, they're not going into the mode of, oh, anything you put in pancreatic cancer is going to be a failure.
In colorectal cancer, I know your time's short, but we pulse, right? So you give capecitabine along with the Avastin, and then if the patient starts to recur, you hit them back with Folfox or Xelox, and you hit them really hard, and then you watch that tumor shrink, and then you go back on to a maintenance therapy. Is that something similar to what you're going to be doing here with pancreatic cancer?
Correct. So ultimately, as you know, John, one of the things that you witnessed is that the subsequent lines of treatment and going back to report, that was one of the reasons why the survival of patients with median survival patients with colon cancer, colorectal cancer advanced, was doubled, tripled. And that's the reason, because you're allowing other drugs or drug combinations being used. And that's what I'm referring to when I say the survival is going to go up, because we are going to be in that mode. But remember, we always thought about treating cancer is that we want cancer to be, if we can, more closer to treating a chronic disease. Obviously, for pancreatic cancer is a long way from now, but it's not impossible if you start to pile up all these drugs. So the other possibility is that you start with let's say, daraxonrasib, and the patient treatment after a year fails. Maybe you can still target the KRAS, but using a different attack mode on the KRAS pathway, a different drug. Like there are degraders that they just make the KRAS protein get degraded. That's another approach, for example. So there are, in my opinion, the opportunities are endless.
Last question before you go. Last.
Let me make I wish this happened 30 years ago.
Well, so do I.
I would have loved to be part of the journey, but that's fine.
You are part of the journey. So you've been part of the journey for 30 years that I've been involved in oncology. So you've always been part of the journey.
Well,
Last question. What
yeah.
about SWOG?
What's that?
What's SWOG doing?
So SWOG is we are looking at exactly what I said in terms of combinations. We're thinking of that. Yeah.
It's
I can't tell you more than that, but we're
I can pry at the next meeting then, after ASCO. Yeah, Philip, we were at ASCO, the plenary session. What a fantastic plenary session. A standing ovation for the RASolute 302 study. Amazing data, as we've already discussed in this episode. I just wanted to see what your insights were from the RASolute final analysis and what your thoughts were on that data that was presented by Professor Walton.
Well, thank you very much again. John, you were there and you noticed how people reacted to it.
Standing ovation.
Yeah.
Unbelievable.
And
Unbelievable.
how often does that happen? In fact, for a disease like pancreatic cancer, which, as you know, for a few decades, we've been trying to find something and nothing came close to being clinically that helpful or meaningful. Now we have something which is really very promising. It's a game changer and a practice changer for sure. So it is really a major achievement, and thanks for all the research that went behind it and the sponsorship of the companies that work to produce these drugs. It is really an advance if you think about it, John, because it's a pill. It's not bringing patients for chemotherapy, carrying a bag for chemotherapy. It's a pill, so it's easier to use. But at the same time, I have to also mention that it has side effects, but the side effects are manageable in a way that really relates to how doctor-patient relationship is in terms of reporting the side effect, and also for the doctors to be, or the nurses to be, very well experienced in how to manage them. We have been in these situations with a number of other drugs that we use over the years, and we know how to really deal with it. So it will be fine. It will be fine. Although one may say, well, there are side effects, but there's no drug we give without side effects. But the side effects can be controlled, and I'm sure you'll find it uh, in a year or two that people are using it very easily, whether the doctors or the patients. The interesting thing is that patients will not need to be going to chemotherapy uh, all the time. They will still need chemotherapy at some point of their treatment, but this really is good to have a pill that you can take at home.
Fantastic news, and totally agree. You and I have been involved with bringing oral therapy to the market, and it's been now being introduced in many, many other agents. So what was the data that you thought in the RASolute trial was outstandingly different to the first discussion that we had in this episode? What was the key points that you would want to bring out from the final analysis?
I mean, one has always to repeat and emphasize the fact that the single most important thing it did was it made people live longer. I mean, that's really the number one, two, three point that I will be very much excited about. However, it also showed that making the tumors shrink, making them smaller, it did in a very good way, better than giving this straight chemotherapy. And as a result of that, it delayed the cancer getting worse. But more importantly, it helped to alleviate the pain the patients usually have. A lot of our patients with cancer of the pancreas do suffer from pain, and this drug appears to be improving the pain management, improving in a sense that they may need less of the opiates and other medications if they are having severe pain, but also giving them a much better quality of life in terms of treatment, because we like patients to live longer, but at the same time, we also like them to be living longer with a good or reasonable quality of life.
It's excellent. And what other outstanding, so the survival advantage is more than doubled, and we've already discussed that earlier. What other advantages did you see in the side effect data versus current standards of care?
So when we talk about when we talk about chemotherapy, and you raise a very good point, actually. I started out with the rash, but when you talk about chemotherapy, we tell patients major side effects. For example, fatigue, hair loss, infection, or susceptibility for infection because the white cells go down, anemia. All these side effects appear to be very minimal or none with this pill. But as I said, we don't get any pill for free, and we do have the skin rash, which happens in the majority of the patients. However, the bad side effects of chemotherapy, which I mentioned, and like the nausea, vomiting, diarrhea, sometimes can be really troublesome to patients. This will not happen with this pill. Another important side effect, which chemotherapy drugs we use in this disease, is neuropathy. Neuropathy, or tingling in the fingers and toes, and not infrequently it leads to early discontinuation of the treatment. That wouldn't happen with this drug. So even in patients who had neuropathy from previous treatment, there's no concern giving this drug, because sometimes, a lot of times, in patients who have received prior treatment, they go on another treatment. There are drugs we can't give because they cause neuropathy. In this case, that's not going to be an issue.
A KRAS inhibitor. Do you want to talk about that as well?
So daraxonrasib is a drug that targets KRAS. You're right. And in pancreatic cancer, over 90% of the patients have the KRAS mutation. The KRAS mutation drives the cells to divide and spread, and also be resistant to other forms of treatment. So this is the key thing about the daraxonrasib. It targets different molecular mutations within the KRAS domain, but not like other genes. It's the same gene. But also daraxonrasib may help in, we don't know yet. I mean, there are studies that are currently undergoing. It may help, for example, lung cancer patients who have KRAS mutation. It may help like patients with colon cancer. But I'm not going to say anything more than just saying potential, because we don't have that data. It's potential. So it's KRAS specific. And that's why we call it targeted treatment. And it's very specific to the KRAS. Now, there are other KRAS targeting drugs that will target only one specific mutation within the KRAS gene. So let me give you an example. So daraxonrasib, when the FDA approves it, it will approve it for all KRAS mutations, and to that matter, for all patients with pancreatic cancer, not even limited to KRAS mutation. But there are other drugs that are being developed that, for example, target the allele or genetic allele or genomic allele called KRAS G12D. So G12D is mutated in only 35-40% of the patients. So the G12D targeting drug will be only used in patients who have G12D mutation. And there is a difference between targeting only G12D or all the mutations. Just to a bit of an explanation there. There's G12D, which is the more prevalent. There is G12V, there's G12R, and there are other rare mutations. But the G12D is the most common, as I mentioned. So sometimes one brings up the issue of which is better, to use a drug like daraxonrasib, which we call it pan-KRAS, all KRAS mutations, or using another one, which is what we call allele specific. At this point in time, I can't make a statement on one is better than the other when it comes to efficacy, benefit. Side effects, it's possible that the G12D targeting only might have less side effects. The other thing is that the pan-KRAS might be also advantageous because it reduces the frequency, or reduces or delays the development of drug resistance because of other molecular changes in the KRAS. So we have to wait and see for these things. But at this point in time, we have a great drug, obviously, for patients who have, at this time, failed chemotherapy. So failed chemotherapy, they have a drug to help them live longer. And as you said, double the survival, so they will live much longer.
Do you see daraxonrasib moving into the much earlier stages, adjuvant, neoadjuvant, in the use of pancreatic cancer?
Certainly. So daraxonrasib already is in clinical trials for earlier stage. So there's the daraxonrasib study, which is looking at the frontline, so newly diagnosed advanced case patients, so newly diagnosed disease, metastatic pancreatic cancer. They will be part of a clinical trial that will be, it's a randomized trial, so patients will be randomized to receive either daraxonrasib alone as a single agent, or daraxonrasib combined with chemotherapy, or the chemotherapy alone. So that will be the study. It's already launched by Revolution Medicine. There's another study that hopefully will be launched very soon, if not launched already. It's in patients who have pancreatic cancer, which is resected, like localized to the pancreas, resected, not metastatic. And then after they receive surgery and the chemotherapy, maybe chemotherapy before or after surgery, or both, after that, after they complete the chemotherapy, then they will be randomized to receive only daraxonrasib for 2 years, or daraxon or placebo, or no treatment.
Okay.
And this is a maintenance kind of treatment, and it will be very interesting because we know that, unfortunately, a lot of the patients who even have localized disease, they go through all the surgery, the chemotherapy and all that, they still can have a recurrence. There's a significant risk of recurrence. So this is to now help in that situation.
Well, Professor Philip, I know that you've got to get back and see your patients and dedicated to both the patient as well as the science. We had a fantastic meeting at ASCO. I can't thank you enough for that. I can't thank you enough for everything that you're doing, both in your own practices and also nationally with SWOGs. It's been a real pleasure, and I want to thank you very, very much, as always.
Well, thank you, John. And I also have to thank you and acknowledge all the good things you do to really inform everyone about what's happening in the field. And that's very helpful because sometimes people need that kind of explanation, and you do a great job in it. And I look forward to see you again in ASCO, but hopefully even before ASCO.
Definitely before. I'll catch you later. See you later. Have
See
a
you later.
great day. Bye-bye.
Bye-bye.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.